aliquot to let you sip your coffee a little bit. So this is a woman in her 60s who presented to our ED with a 1 week history of painful papules in the left hand. So she states she was in her usual state of normal health until 1 week prior, when she noticed an erythematous rash on her left index finger in web space that gradually progressed to her left thumb. Pain was described as burning and pulsatile. Her PCP prescribed a steroid cream, hydrocortisone, that resulted in no relief of symptoms. The lesions then became swollen, resulting in limited range of motion of the index finger and the thumb. She has no fevers or chills or other symptoms aside from those on the hand. And with patient permission, I have a picture to share with you all to show you what we're dealing with. So let me see if I can share my screen. I'll just have to request access to the screen share.
I got you. Give me 1 second.
Thanks, Jack. Okay, so this is what her hand looked like when she made it to the hospital. And that's the end of the first aliquot.
All right. Well, I think anytime we start off with a case of a rash, I think we have to ask ourselves a few questions to sort of anchor ourselves in an approach to the rash. I think one of the first questions that I oftentimes ask is this an inside job or an outside job? And we can use the sort of distribution and the character of the rash to get a sense of this. Inside job usually means that there's some sort of systemic illness that's happening in the body that's leading to the development of a rash, right? One characteristic example of this that you could think of would be something like a systemic viral syndrome that has a viral exanthem associated with it, right? Those are usually going to be more diffuse, more widespread as a rash characteristic. Whereas if you think about an outside job, right, we could think about something like a skin and soft tissue infection of an extremity, right, like of the foot or the leg, right? Outside jobs are usually going to be unilateral, focal, and usually involve parts of the body that come into contact frequently with the outside world, right? So things like our upper extremities and our lower extremities. The next thing we have to ask ourselves is, are there any other red flag symptoms associated with this illness, right? Red flag symptoms could include things, for example, like underlying systemic symptoms, right? Fevers and chills associated with the rash actually can oftentimes don't necessarily point us more towards inside versus outside, but they just help us to frame the severity of the rash. Other red flag symptoms include things like, is there mucosal involvement, which brings us into the thinking about some of the dermatologic emergencies, right, like SJS or TEN. And then another important question is going to be whether or not the rash is painful, right? If you just think about any time that you've had a rash, at least last time I had one was an allergic reaction to some new skin products, was not necessarily painful, right? It may have been itchy, it may have been erythematous, but it wasn't necessarily painful. And so pain can also be another important finding that helps us characterize where the rash is ultimately coming from. And looking at this rash and hearing the history that Andrew gave us, there are some interesting features here, right? Just by virtue of the distribution of this rash, right? The fact that it's on a single distal upper extremity, that might point us towards it being an outside job. But there's some other features of the rash here that make me wonder about the possibility of an inside job, and particularly an endovascular source. That includes things like the pulsatile nature of the rash, the fact that we see what looks like maybe some areas of necrosis, particularly in this part of the thenar eminence here, where it looks like there is some sort of violaceous, non-blanching component of the rash with maybe some overlying skin component, some overlying necrosis in the area. So what I'm honestly trying to do right now is get a sense of, or what we're seeing here something that came from the outside world and is causing some sort of infection of the hand that's leading to skin necrosis, or are we actually dealing with an inside job, an endovascular problem that happens to be getting stuck and blocked in the distal upper extremities where the blood vessels are very, very small and where things like clots or emboli are likely to get stuck? Charmaine, what are your thoughts here and sort of hearing about this and seeing the picture of the rash itself?
Oh my gosh, I love that approach. I love the inside versus outside job. I'm right there with you. I think when I was looking at it, I'm like, is this more of a vascular pathology, or are we dealing with like a skin and soft tissue infection? And I think you just kind of hold those in parallel to each other. and look for the systemic signs of infection that can cause, as you mentioned, like endocarditis, those things. The other thing that I was like thinking about with the hand is that if this is skin and soft tissue, could that potentially be a bite mark of some sort? So when it comes to the hands, then like getting a good exposure history, I saw a lot of gardening pearls in the chat. So has this person's been gardening in the past, having any animals at home, dog bites, cat bites, sometimes human bites are the worst when it comes to the infections that they can carry. And so I think like that's what I would do. And whenever I am worried, if this is someone that I'm seeing in the emergency room or in clinic or in a hospital, I just the functionality of it is really, really important. So very low threshold to have your subspecialties involved. A lot of the time in our hospitals, our plastic surgeons, and because you don't want to, again, like miss a bad infection or anything that could potentially damage the functionality of it. So those are my initial thoughts. Andrew, back to you.
Okay, perfect. Some answers to your questions. So she denied stick contacts. She denied recent trauma or insect bites to that hand. No recent travel history. No medication exposures apart from the steroid cream that I mentioned. She denied contact with seawater, although she frequently cooks salmon and tilapia. She's not been gardening or camping. She's only in contact with a dog and a cat that are well known to her at work. She sometimes uses gloves at her work. No contacts with new chemicals except for maybe a different hand soap. And for past medical, she has early stage renal cell carcinoma that actually resulted in a nephrectomy some years ago. So considered cured, although the history is a little bit muddy. And I'll just stop there for this aliquot.
Yeah, thanks so much. I think in terms of again, like with that history, the trauma. Thank you so much for mentioning that. That's also another that could be a nidus for both vascular issues and also a potential for nidus of infection. And I think. In terms of like exposures, we have a cat and a dog, but it doesn't seem like there is any bite mark. And with her cancer that is potentially cured, this is not someone that I would assume it's immunocompromised unless like there's something else in the past history or like any behaviors that we're missing. And if a dog and a cat is well known and vaccinated, I think the chances of those being a reason for an infection is like much lower. For now, I think like the gloves is interesting. There's nothing that jumps out to me with someone who's like using gloves, unless like there's something going on in the gloves that can potentially be a nidus of infection. But really, no, nothing in my mind that jumps out to me. And the other thing that I was like kind of a little bit thinking about, that this is going on for a week and it sounds like there is some extension. However, if this was like pyogenic infection, a week is a very long time, and usually they tend to expand faster without any treatment. So I think like if there's a new soap or anything, like there raises possibility of something like contact dermatitis or some sort of allergic reaction. However, again, like she's not giving a history that is consistent with that. Jack, and what's coming up to you?
No, I'm right there with you. I think I think you did such a phenomenal job of sort of summarizing the case that is falling apart for this being an outside job, right? I'm with you. I don't know necessarily what to make of gloves, other than her hand is probably protected from other things here, or from things in the outside world that may cause disruption to the skin integrity. I think if we are going to sort of explore the hypothesis of an inside job, I think exactly as you said, Charmaine, from the beginning, the possibility of an endovascular phenomenon starts to come up. I think that case is strengthened both by some of the features of the rash itself, and then also I think one of the things that I'm not necessarily putting a huge amount of weight on, but I would say like I'm feeling some curiosity about is this history of renal cell carcinoma, particularly the fact that it's cured with a question mark. The reason that I bring up RCC here is for two reasons. is that RCC is notoriously a vascularly invasive cancer, right? So oftentimes we can see RCC be associated with renal vein thrombosis, invasion into the IVC, and thus embolic showers that can potentially extend from there. And so I think if we're actually, how do I say this? So I think just having RCC in the background with a potential vascular appearing rash, I think the possibility of a connection between those two things becomes interesting. The other thing about RCC is that it is also notorious for having a variety of different paraneoplastic phenomena associated with it. That can be anything from anemias, cytopenias, thrombocytosis, as well as ectopic hormone production, whether it's something like paraneoplastic ACTH production, SI, ADH, or hypercalcemia of malignancy with PTHRP. But also it can be associated with other paraneoplastic phenomenon. For example, if we were to say that there is potentially a central embolic source here that's causing these to come to the fingers, non-bacterial thrombotic endocarditis comes into play, right? So if we just rewind this piece of thread that I just unraveled in front of us here, I think really the first question is to say, what does it mean cured question mark? Because there's a variety of different treatments that we can have for RCC. Some individuals are cured via nephrectomy, in which case it is a local malignancy and the kidney gets resected. And the vast majority of those individuals do very, very well, right? Sometimes some of those cells can be left behind and can seed the peritoneum along the way, but that's, as surgical techniques have improved, that's a much less common complication here. But other times it's cured via a more chemotherapeutic approach, right? And in those cases, someone is more in remission rather than necessarily completely cured because the cancer hasn't necessarily been fully resected from the body. So thinking about what cured question mark means here, and if we are in the space of remission, then certainly the possibility of a recurrence comes up. And even if this is somebody who had a nephrectomy in the past, there's always the looming possibility that some of those tumor cells were left behind or had metastasized before the surgery itself. And now we're seeing it start to crescendo again.
All right. You two are well poised to get the final diagnosis here. So I'll give you the final aliquot. So her vital signs were normal when she came in. Her lab showed negative blood culture, a normal metabolic panel, a normal CK, a white count of 11,000 with 73.5% neutrophils, a high sensitivity CRP of 19.9, which is elevated, and an ESR of 42, which is elevated. And there was a Doppler study done of that presenting hand that was normal for vascular anomaly. And something I hid at the beginning of the case, because it's just such a huge pivot, is that actually she has symmetric findings on the other hand, which I can show you here. That should be really helpful to you too. This is what her other hand looks like. And that is the last aliquot.
All right, I think this one is coming to me. Sorry, I'm just mesmerized by the hand findings again. So I will lead from this saying that I do not necessarily have any high degree of confidence in what the final diagnosis is here, but we'll at least sort of talk through some of the things that are at play here. The finding of the bilaterality of the hands, I think, really increases the possibility of a couple different things. One of them is that there is a central source of emboli that is leading to distal showering of blood clots that could be causing vascular obstruction and occlusion of vessels that could be leading to some cutaneous ischemia that we see here, right? Looking at some of the features of the rash on both hands, there's a duskiness to the surface of the skin that looks like there's some necrosis, and also the fact that there is this sort of palpability to it, right? Makes you think about, okay, is there some sort of clot that's depositing in the soft tissues? We're seeing leakage of blood and potentially even something like immune complex deposition, and then also obstruction of the blood vessels that would lead to something like a palpable nodule as well as surrounding ischemia. So the possibility of a central embolic source here seems to be one that comes up given the bilateral nature of the findings. And then the other possibility is that these are actually just representing palpable purpura, and what we're dealing with is not necessarily a central embolic source that's leading to a vasculopathy, but that what we're dealing with here is actually a vasculitis. And if we think about the vasculitides that can cause these types of skin findings, it's usually the small vessel vasculitides, but sometimes the medium vessel vasculitides as well. I mentioned medium vessel here because if we think about things like polyarteritis nodosa, they can cause skin findings that look a little bit different than the classic small vessel vasculitis findings we see in something like GPA. Those are usually palpable purpura scattered throughout usually the lower extremities, but sometimes the upper extremities, whereas polyarteritis nodosa can have palpable, more nodular lesions, which is a reflection of the larger vessels that they happen to involve. Again, PAN being a medium-sized vasculitis, GPA and MPA being a small vessel vasculitis. I, though, am kind of stuck beyond that. I think really what I would be reaching for in this case would be an echo to see if there's a central source of emboli, potentially looking at the aorta to see if there's something like an atherosclerotic atheroma or some other involvement of any of these large central vessels, and then potentially getting a biopsy of the skin and soft tissue, right? A small vessel vasculitis and biopsy usually looks like a leukocytoclastic vasculitis. I don't know what the pathology of the medium vessel vasculitides are, but maybe Charmaine can help us out there. But I think those are probably the two leading hypotheses here. Again, inside job being most likely, inside job being a central source of emboli, or inside job being a more systemic illness that happens to just be manifesting in the hands right now.
I could not agree more. Yeah, it would be like kind of the most drastic presentation of like vascular pathology for endocarditis that I have seen. But again, like I think thinking about whether clearly this patient is inflamed, right? Like systematic ESR CRP is up. She has a leukocytosis, so this patient is inflamed, and the question becomes like, oh, is it infection? And I think in this case, you gotta have to rule that out, especially if then the second thing that we're considering is like a vasculitity because of the treatment that it entails. I've seen kind of like hand necrosis being mentioned with like Kawasaki as well, but I think it's like mostly in children. I'm not sure about that either, but like those are again like the two things that came to my mind as well. It was like kind of rule out infection, especially with endocarditis, and the second would be like a vasculitides. Wegener's is another one, and as well, which I think Andrew mentioned that she doesn't have any smoking history either. So that is where my brain is. I really loved your whole discussion about the complications of RCC as well. So I think like those are like kind of the top three things that we're thinking of. But I don't know if I honestly confident enough to put a Nicole down. What about you, Jack?
No, I don't either. Yeah, I don't either. Yeah, I appreciate you mentioning Burgers, disease, thromboangiitis obliterans.
I call it Wegener's, but really I guess I mean Burgers. Thank you.
Yeah,
You're the kindest. Like, did you guys see how kindly he corrected me? You're the best. Yeah.
It's a great thought. It's a great thought, right? Particularly given the hand nature. And I saw that Carolyn asked a great question in the chat, right? Usually it's associated with cigarette smoking, and I don't know, right? Could there be an association with RCC? It certainly seems plausible, but I don't know the answer to that. But I think given how vascularly invasive RCC can be, I think a direct complication of the tumor versus a perineoplastic complication. I really like that you brought that up, Charmaine.
Yeah. All right, Andrew, teach us.
Okay, no, this is a great discussion. This is exactly how you should approach this case, the way you two just did it. So basically when I inherited this patient, I knew the findings were symmetric and bilateral at that point. And, you read all the notes and everyone's initially concerned about necrotizing skin and soft tissue infection. If you just look at one of the hands, as you said, it's super concerning that they have some sort of like necrotizing skin and soft tissue infection or some sort of other skin necrosis, hence prompting the Doppler of the hand. But again, it was bilateral and symmetric, which would be really, really odd for that. So they did end up biopsying the lesion, which showed a dense neutrophilic infiltrates, and all infectious stains were negative. So we gave this patient prednisone, and within 1 week, her lesions rapidly resolved. So the diagnosis was actually Sweet syndrome. And particularly, there's a variant of Sweet syndrome called neutrophilic dermatosis of the dorsal hands that is basically like textbook, this picture that I just showed you guys. So let me just read a little bit about that for you. And someone says well named in the chat. Charmaine, yes, it's very, very well named. Because what had happened is I thought it looked a lot like Sweet syndrome, but I never heard of this variant before. But we just put it in the the Google, Dr. Google, and sure enough, like top search, you get this variant of Sweet syndrome that comes up. So this is well, first of all, Sweet syndrome is one disease on the spectrum of neutrophilic dermatoses, and it's a group of disorders united by a sterile neutrophilic infiltrate on histopathology. So the diagnosis of classical Sweet syndrome can be made when you have an acute onset of painful erythematous nodules or plaques accompanied by consistent pathology, which is this dense neutrophilic infiltrate without evidence of vasculitis. And then 2 of 4 minor criteria, including excellent response to steroids, which this patient had, presence of fever, which this patient didn't have, high inflammatory markers, which this patient had. And then there's also association with underlying malignancy, inflammatory diseases, pregnancy, or recent illnesses or vaccination. And the numerous clinical variants of Sweet syndrome have been described, including pustular Sweet syndrome, necrotizing, and this neutrophilic dermatosis of the dorsal hands. So usually, as in the name, these lesions are limited to the dorsum of the hands, often located in the area between the thumb and the index finger. And given the diverse clinical presentations, the differential diagnosis is broad for this, and it does include infection, neoplasms, and autoimmune disorders. And interestingly, because central necrosis and ulceration, this patient kind of looked like they had necrosis in the center of the lesions, that can be confused for infection. There are actually case reports of people actually getting like resections of their hands because people are concerned there's some sort of like gangrene going on, and then they resect it. But because this is a neutrophilic dermatosis and you can have pathergy in some of these cases, they resect the lesion and then it just gets worse afterwards. So there's a case report of a patient whose index finger was cut off and then the lesion just gets worse after, hence the diagnosis of Sweet syndrome afterward. So about 78% of patients have bilateral disease, approximately 4% of patients have palmar involvement, as in this patient. And I'll just stop there. It's super interesting. Again, Dr. Google wins the day here. You put it in and it comes out. And yeah, this one just kind of fell in my lap. I'm curious what your reflections are.
Oh my gosh, Andrew, you're awesome. No, it's not Dr. Google who won the game, it was you, because you framed it so well. And it's you who put that in the Google. So credit to you. Oh yeah, I was not thinking about Sweet syndrome, and kind of like doing a cognitive autopsy. I think in my mind, fevers and Sweet syndromes, it's so connected that when I was like, oh, the patient's febrile, I thought away. I wasn't even thinking about it. So even didn't come to my mind, which kind of shows you how, we make these associations that are not always correct. So this was such a great reminder. And then Sweet syndrome, oh gosh, I need to go read some more. It's complicated. It's a big world. They can present a lot of different ways, but kudos to you, Andrew. You taught me so much today. Jack, what are your thoughts?
No, I'm with you. Yeah, it's a super fun diagnosis to get to revisit, and I think there is always, or I think one of the things that I think through with these cases, whenever in the frequent moments when I don't know the diagnosis, is was this because there was a piece of information that I didn't know about a disease? Was it because of inaccuracies or maybe incorrect weighing of probabilities, or was it actually a disease that I didn't know enough about to even consider? Right. So it's like, did I not know about the disease overall? Did I not know about the piece of disease, or did I have the information needed, but didn't necessarily weigh that information correctly? Right. This time, right, I'm at the very, very base of the pyramid. It's a disease that I don't know enough about to make the diagnosis on my own, which is honestly the most fun place that I find myself in, because it's like there's this whole frontier of things to learn about it overall, and not only things to learn about the disease, but to think about where to organize it in the overall mind, or in one's overall mind, of like what it sit next to. In my mind, Sweet syndrome, in terms of the little that I do know, sits next to cancer, like a hematologic malignancy plus rash, and now it gets to find a new location in terms of both how it presents and what other findings it might be associated with. So yeah, thank you for bringing this, Andrew. This is a really great case, and I think also one of those opportunities to really dive into that sense of, in the cognitive autopsy, was it because I didn't know something overall, because I didn't know a specific piece of information, or because I didn't necessarily weigh things correctly? So yeah, back to the basics, and we'll get to build from there.
I love it. Couldn't agree more. Both Jack and I will be doing some reading today. Thank you so much, Andrew. Really appreciate you. Thanks, Ibrahim, for scribing. And yes, the mic is yours.
Thank you. Thank you again, Dr. Andrew. Amazing case. I think we all have some reading to do today. And also, thank you for this amazing discussion. So for our teaching points in approaching to a rash, we can categorize it in an inside versus outside job. First, we can characterize it as extrinsic factors versus intrinsic factors, whereas the extrinsic factors may cause unilateral, focal, and involved parts of the body that are in external contact. And the intrinsic factors, which could be vascular, are pulsatile in nature, violations, and non-blanching. We can also think vascular versus soft tissue and skin involvement. Now we have to also consider red flag syndromes such as mucosal involvement, pain severity, and info about underlying systemic infections such as fever or rash in other places that could frame this severity too. Other points very important are what is the distribution? For example, a systemic syndrome rash can be more diffuse and widespread if the patient has any kind of exposure, animals, travel history, environmental exposure, any hobbies such as gardening, or what is their job. Also, the time of evolution is important with determining allergy as a factor, since this progresses fast. And as a very important peril is to remember that renal cell carcinoma is notoriously vascular invasive, whereas it can get to the renal vein thrombosis, can cause inferior vena cava invasion, and has many paraneoplastic syndrome associated. And we should also consider remission or metastasis. Now, we started in an approach to the inside job in a vascular versus vasculitis, whereas a bilateral involvement made us think vascular, because a central source, for example, an emboli that can cause this distal showers and list obstruction can cause ischemia and present this way. But do not forget that vasculitis, such as median vessel vasculitis as polyarteritis nodosa, can cause nodal lesions, and many others can present this way. And again, thank you for the teaching pearls for Dr. Andrew. And what stuck to me is that this differential diagnosis for Sweet syndrome can be very, very broad. With infection, neoplasm, and autoimmune. And remember that around 78% of patients may have pulmonary involvement for this type of Sweet syndrome. Again, thank you so much for everyone. And the discussion was amazing. And yeah, thank you.
Boom. That was awesome, Yasmin. Thanks for that awesome teaching point, Andrew. You're awesome. Ibrahim, thank you. All of you are so awesome. Thanks for all of the amazing comments and chat. We can't wait to see you guys next time. Bye. Have a good day.